Dear Chair, dear audience, let me greet all of you and allow me to present the progress of my PhD thesis, Effect of Anti-Inflammatory Medication on Venous Thromboembolic Risk in IBD Patients. I am Hajnal Székely, working as a medical doctor at the Department of Surgery, Transplantation and Gastroenterology with the vision to improve the IBD patients' quality of care by extending the knowledge regarding some important clinical aspects of this complex systemic disease. So within our project, we choose the venous thromboembolism as a complication of IBD. And as the role of the anti-inflammatory medication is still a matter of debate, we aim to assess the impact of the most commonly used medications in the form of a systematic review and meta-analysis, and plan to assess the role of the newer drugs within a prospective study. So it is known that patients with IBD have a around 2- to 3-fold increased risk of venous thromboembolism compared to the general population. The average prevalence of this complication, it is reported to be varying between 1% and 8% in observational studies, although being remarkably higher in autopsy reports. If this complication appears, it is considered to be a relevant cause of morbidity. It results in longer hospitalization, has a tendency to recur, but of utmost importance is the fact that may be potentially fatal. The mortality rate of these events, it is considered to be between 8 and 25%. These events are considered to be always multifactorial in IBD, and besides well-known risk factors, here we should take into account some disease and treatment-specific characteristics like extensive disease in ulcerative colitis, colonic localization and fistulizing behavior in Crohn's disease, as well as active disease flare-ups and consequent hospitalization in both disease phenotypes. Regarding therapy-related risk factors with proven effect, the surgery and the need for corticosteroid therapy have a role. Regarding other treatment options which are available in the treatment of IBD and their potential relation to venous thromboembolism, the data are relatively scarce. If you take into account the tumor necrosis factor alpha, it's a driver, a pivotal molecule in the inflammatory process in IBD, but also it may activate the coagulation cascade, we may presume that by inhibiting this cytokine, we may achieve not just proper controlling of the inflammation, but also we may interfere with the coagulation process. Our aim was to determine and compare the effect of anti-TNF drugs with conventional IBD therapy on this venous thromboembolic risk. So for the clinical question that we formulated, we used the PICO framework, and our hypothesis was that TNF drugs are associated with decreased odds of these events compared with the conventional therapy. So for data collection, we pursued a comprehensive systematic search in the most common 5 electronic databases, with the search key containing the domains of the disease, of the complication, and of the chosen biological drugs. At the end of the selection process, out of more than 10,000 hits, 18 articles were considered eligible for inclusion. We were able to include just observational, mostly retrospective studies, case-controlled trials, as randomized controlled studies are not available in this topic. So to assess the probability of the events in patients treated with biologicals versus those on conventional anti-inflammatory therapy, we choose as a measure of effect the odds ratio with a 95% confidence interval, where an odds ratio of 1 means that there's no difference between the effect of the interventions. Taking into account the significant between study heterogeneity, we use the random effects model. We also determine the proportion of these events in the mentioned treatment categories for more appropriate data. As you see here, calculations confirmed an odds ratio of 0.42 in the favor of biologicals compared to those patients treated with corticosteroids, and this effect turned out to be statistically significant. The proportion analysis also showed us that patients treated with biologics were less frequently affected by this complication compared with those on the steroid therapy, meaning in the clinical practice that those patients who have active disease flare-ups and considered to be at highest venous thromboembolic risk should be treated preferably with biologicals, taking into account the so-called pro-thrombogenic effect of the corticosteroid therapy. And we used a similar methodology to compare those patients treated with biologics versus those on immunomodulators. Here, summary of the data showed again that neither the odds nor the proportion of these events showed any difference basically in these two mentioned categories. And similar results were found when comparing patients treated with either anti-TNF drugs or 5-aminosalicylates, meaning in the clinical practice that regardless which treatment strategy we choose to assure long ongoing remission of patients with IBD, we are going to encounter similar probabilities of these complications. So the strength of our work, it may be that we assessed through a comprehensive work basically the possible effect of the most commonly used medications on the venous thromboembolic risk with using a rigorous methodology and in a relatively high number of IBD patients. Obviously, there are some limitations that should also be encountered, like, as I mentioned, the included studies were observational, mostly retrospective ones. We are aware of the heterogeneity of the IBD population, as well as the many confounding factors that have to be taken into account when we would like to assess the role of each and every of them in the added or compound venous thromboembolic risk, and also the concomitant medication, which is a common practice in patients with IBD. It makes relatively difficult to assess precisely the role of each and every drug in the added venous thromboembolic risk. So taking into account all of these limitations, there's a very low certainty of evidence of our data. Still, we would like to raise awareness of this rare but severe complication of IBD and underline the fact that individual risk assessment should be done in each and every patient's case because it may interfere with the optimal treatment strategy, as well as we would emphasize the importance of the so-called steroid-sparing therapy in patients who have active disease flare-ups and are considered to be at high venous thromboembolic risk. And also, we would like at the same time to point to the future as prospective, large, well-designed and well-conducted studies that are needed to more precisely assess the impact of individual drugs on venous thromboembolic risk. So we are glad to report that our work was accepted and published in the Journal of Crohn's and Colitis. And in accordance with the conclusions from the first study, in the second project, we aim to detect and compare the role of newer biological drugs and small molecules in laboratory markers of this IBD-associated increased venous thromboembolic risk. There's ongoing evidence and growing evidence about a crosstalk and mutual influence between the inflammatory and coagulation systems, and now it is considered that the activation of the systemic inflammation is the major risk factor of this increased venous thromboembolic risk in patients with IBD. And regarding the so-called vascular hypothesis, the role of the endothelial dysfunction, it is really remarkable, which may be activated both by the local gut and the systemic inflammation. So taking into account all of these data, we aim to determine and compare the effect of newer drugs on the laboratory markers of this IBD-associated increased venous thromboembolic risk. So to answer our clinical question, we are going to use the PICO framework, and our hypothesis is that these drugs are going to be similarly altering these relevant laboratory parameters. So we plan to conduct a prospective multicenter study within which we are going to assess the hemostatic profile of the IBD patients. These results are going to be compared between the different groups, which are going to be stratified, among others, by their anti-inflammatory medications, with the goal to measure the possible effect of these medications on the laboratory parameters. Obviously, we are going to exclude those patients who have recent venous thromboembolic events or in whom their comorbidities or current medication interferes relevantly with the mentioned laboratory parameters. So we are at the start, or the initial phase of our project, writing the pre-study protocol. So to sum up, we choose the venous thromboembolism as a major complication of IBD, and we plan to assess the role of the most commonly used and of the newer ones in the regard of this increased venous thromboembolic risk. Our data was presented in national and international forums. symptoms. And I would like to mention that I'm working also as a co-author into other systematic reviews and meta-analyses. So I'm going to thank you for your attention with a quote. The scientist is not a person who gives the right answers, he is one who asks the right questions. So obviously I'm not going to give you the right answers, but I'm waiting for your right questions. Thank you.
Congratulations for the nice presentation, and the paper is open for discussion. Any questions from the audience? Okay.
Congratulations for your nice presentation. I have questions regarding your first topic. You included IBD patients. I assume that you could include also ulcerative colitis and Crohn's disease. Did you see any differences between the two diseases regarding the effect of TNF inhibitors?
Thank you for your questions. There's a debate regarding the appearance of this complication in the two disease phenotypes. Data are relatively different based on the reports. We did a proportion analysis, as I mentioned also, and from 4 or 5 studies which were reporting the both disease phenotypes basically, we were able to do just the proportion analysis also, not the determination of the odds ratio. And although there are some difference between the mentioned treatment categories and the appearance or the occurrence of the venous thromboembolism, these are not significant differences. Basically, we may state, or currently the data are showing us that it may be slightly more frequent in patients with ulcerative colitis, but the difference is not significant. Both patients of both disease phenotypes and both sexes are relatively equally affected by this complication.
Okay. Congratulations, actually, and also for the first, the paper in GCC. It's a really nice result. I was just thinking about, so you compared actually 3 different compounds, anti-TNF antibodies, steroids, and 5-ASA. And as far as I know, steroids are mainly used only to induce remission, but the other 2 also for maintaining remission. My question is, did you enroll only patients who were in the first phase of the treatment, so in which the remission was induced? So I don't know whether it's understandable what I ask. So
So we are talking about the first project?
Yeah, first project. So actually, if you are considering the role of TNF blockers on this VTE, in this case, does it matter whether this is an acute treatment or a chronic treatment? Because actually, I would say only the acute treatment is comparable for the effect of steroids.
Thank you for your question. Well, obviously, TNF inhibitors may be used for induction of remission and also later on or ongoingly for maintaining of the achieved remission. And you are absolutely correct. Corticosteroids may be used just for induction of remission in patients with active flare-ups. So that's why I just mentioned that in these 2 comparisons, these are the patients who have active disease flare-ups treated with either TNF inhibitors or corticosteroids. Both of them are used for inducing remission, obviously, and in these patients in whom basically the venous thromboembolic risk, it is considered to be at highest compared with the others, as the systemic inflammation is the main risk factor of venous thromboembolic events. That's why the comparison here may be done. In the other 2 categories, because the anti-TNF drugs may be afterwards used for years for maintaining remission, that's why the comparison was done. We do the other 2 types of drugs, immunomodulators or 5-aminosalicylates, which themselves also are used on the long run, obviously depending on the activity and many other disease characteristics on patients for maintaining the remission.
Okay, no, I understand. Yeah. And how would you explain that, for example, 5-ASA was as effective as the anti-TNF blockers in this case, but the steroids less?
it's a logical question again, thank you. We suppose that those patients, relatively a small fraction of patients are well with monotherapy, which may be the 5-aminosalicylates, but there may be this fraction of patients which are ongoingly in remission with this monotherapy even, maybe having decreased its odds of these events, because again, the systemic inflammation plays the most important role in this case. Obviously, as I mentioned, it is difficult to create really homogeneous IBD patient groups because the concomitant medication, it's a confounding which should be always taken into account. So when we assessed or gained the data, we were paying attention to how these were reported, the medications were reported. Obviously, the most objective clinical markers of the disease activity should be usage of those clinical indices that are relatively objective. They were not reported in all of the studies, and in several cases, the used medication was basically used as a proxy of the disease activity rather than the more objective clinical indices, which would have been really nice and more precise.
Okay, thank you.
Now, as we see this slide, I mean, here and in some other slides too, I mean, it shows up that the certainty of evidence is very low. I mean, of course, I mean, you could still publish this, but that means that there are certain kind of bias and even systematic errors in the studies. So what were these, and then how can you avoid, if that's possible, in your own research actually, what you are just planning in your second original study?
Thank you for your question. So we decreased the basically low evidence, certainty of evidence because of the included studies design. Again, there were just observational, retrospective, cohort and case control trials or population-based data. So we don't have randomized controlled studies. So that's what we're starting for a low evidence of, a certainty of evidence. And based on these many confounders which should be taken into account, the studies design, the different characteristics of the IBD population, the medication used, the concomitant medication, and so on. So these were the imprecision of certain data. Those were the reasons why we downgraded the certainty of evidence all over.
So some of them you can avoid, some others you cannot
because of the characteristics of the patient population and because of the characteristics of the medication used. Basically, it's impossible to do like really homogeneous data group of patient groups and to have really precise data. That's why these are estimations basically, but they are in concordance with the current knowledge and the current literature data.
Further questions?
Yes, congratulations. Yeah, I'm sorry. Go ahead.
Congratulations to your presentation and publication. So I got two questions. First of all, in your current clinical practice, did you change your practice based on your results? Like these patients with high risk of thromboembolism, are you starting already with anti-TNF, like the first option? And my second question would be, if you have any information or knowledge regarding the anti-TNF versus placebo and the risk of thromboembolism in these patients.
Thank you for your questions. We changed our daily clinical practice, but not in this regard, because we prefer to initiate early these biological drugs for many reasons instead of continuously or repeatedly administer corticosteroids. But the changing in the practice was in that regard that nowadays the recent last year published European Crohn's Colitis Organization guideline states that each and every patient who is hospitalized because of an active disease flare, independent of which type of medication they are going to get in remission, they are mandatorily they should be mandatorily treated with preventive dosage of low molecular weight heparin. So that's an additional thing. Obviously, with proper controlling of the inflammation or of the activity of the disease, it's a main thing, but otherwise these are not going to be preventing this complication. Preventing means that we have to administer LNVH, and nowadays it's a recent practical consideration that we use in the daily clinical practice. That's the changing in this regard. And the other question, there's no such thing that placebo-controlled trial in this regard. So I think it would have been unethical to, let's say, randomize patients in this regard, because venous thromboembolic events are potentially fatal complications of IBD. Or let's say if they are going to be localized in the central venous system, then maybe having really severe complications on the long run. So to my knowledge, there's no such thing that placebo-controlled trial in this topic.
Congratulations to your wonderful work. I'm not a clinician, so maybe my question is not that relevant, but you mentioned that anti-TNF alpha should be considered in patients who are at high risk for this venous thromboembolic event. And how you can define these patients' population, and what can be a risk factor of it?
Okay, thank you for your question. It is really important to see that IBD patients, the thing or the fact that they have the active disease flare-up, it's a factor in the regard of venous thromboembolism. But as I mentioned, beside disease and treatment-specific characteristics, there are all of the other well-known risk factors from other patient populations like age, obesity, immobilization, central venous catheter, other comorbidities, which should be also taken into account, and that's why you individually have to assess each and every patient's risk, and their added effect is going to be really important. Among others, obviously, the activity of the IBD, which is considered to be an important risk factor again, but we have the patient with other comorbidities, other disease characteristics, other characteristics basically, which altogether should be taken into account, besides the fact that they have an active disease, either they are inpatients or outpatients, or there are many factors that are going to be added up together in this compound venous thromboembolic risk assessment.
Thank you.
You basically answered partly my question, because I wanted to ask that you mentioned that there are no randomized controlled trials, and why is that, or what the reason is that there are no such studies. And my second question is that what is the main difference between a randomized controlled trial and an observational study, and what other subgroups of observational studies are you aware of?
Thank you for your question. So the main difference is the presence or not presence of the intervention, and in this case the trials may be randomized or non-randomized, and the other category we have the observational studies, which may be either, depending on the direction of the exposure or outcome, we may talk about cohort studies, case control studies, or crossover trials.
Okay. Further questions? Are you planning to compare also the TNF blockers with other biologicals?
That's the goal of the second project.
Okay.
Because it was always a logical question why it's not part of the first topic, because when we did the systematic search, there were no available data or enough available poolable data in this regard. So that's why we are going to plan to assess these effects prospectively.
And are there any differences between infliximab and adalimumab, or it doesn't matter?
It doesn't matter. There's no really important difference. It's a group effect, basically.